will be attending to your requests. So today I'm going to talk more specifically about magnet function, but I'm also going to introduce you to some basic pacemaker concepts, like what would be the indications for somebody to get a pacemaker, what would you expect to see on telemetry for the patient with a pacemaker, and also use of magnets during surgery for pacemakers as well as defibrillators. So what are some of the common pacing indications? Why would somebody get a pacemaker? So as you know, at its simplest, this is a simple definition here. If you want more detailed information of the various indications for pacing, I have sent a link to Lisa, which basically is a paper. It's a paper in circulation from 2017, which has the complete list of indications. There's a whole slew of it, and I could talk for hours if I only spoke about that. So I've condensed that today, just for a brief understanding. You would get a pacemaker if you had symptomatic bradycardia. So let's say your sinus node, where the electrical impulses arise. With those impulses, you know that your sinus node controls your heart rate and keeps it between 60 to 100, right? So if your sinus node has any issues, or it's called sinus node dysfunction, or sixth sinus syndrome, it cannot release those impulses at the rate you want, and those patients are typically called chronotropically incompetent. So they cannot increase their rate, and they are symptomatic. So the key word here is symptomatic bradycardia. If you're not symptomatic or you're asymptomatic and you have a lower heart rate, like in the 40s, nobody's going to put in a pacemaker into you, okay, or in your patient. So it has to be symptomatic bradycardia, sinus node disease, which is kind of goes together with that, and complete heart block. So somebody has the electrical impulses from the sinus node. If they're not able to reach the ventricles, there's some block in between. It might be at the AV node or below, and your ventricles don't get those electrical impulses. That's called a complete heart block. And if a patient has a complete heart block or a complete dissociation between the P waves and the QRS complexes, it's called a complete heart block. Okay? In those patients, definitely are getting a pacemaker because their conduction system is not working properly. And chronotropic incompetence are those patients that cannot get the sinus node cannot get their heart rates higher. So you need the top portion or the atria to be paced for them to regulate their heart rate. Okay? And also, if you have a Wenckebach, a patient with a Wenckebach, or a Mobitz type 1, I hope you know what a Wenckebach is. Every third beat or so is dropped. And those patients usually would not get a pacemaker unless they are symptomatic. Okay, and type 2 blocks, so 2 to 1 block. So for every 2 P waves, you have 1 QRS complex. And the P to R intervals do not change for this every second complex, or can be 2 to 1 or 3 to 1. If you have a type 2 block, you will get a pacemaker. Okay? So these are the indications. These are very basic. You can get, so there are other examples, like somebody has a 4-second pause. There's nothing coming through for 4 seconds. 3 seconds or greater, you would get a pacemaker, even if you're asymptomatic. But if you're symptomatic with a 3-second pause, you'll get a pacemaker. Okay, you had syncope, 3-second pause recorded, you'll get a pacemaker. So what are the indications for ICDs? Are you all aware about the difference between a pacemaker and an ICD? Mm-hmm. So an ICD is a pacemaker with a defibrillator function to it. Okay? So not all patients necessarily require it for pacing, because there might be a patient with a heart block or a sinus node dysfunction that might also qualify for an ICD. That's when the pacemaker function in an ICD is really required. Otherwise, you can basically separate these patients into 2 categories. One is secondary prevention, patients that require secondary prevention, meaning that they already experienced some kind of a sudden cardiac arrest. Okay, there are a lot of clinical trials which showed that patients that had sudden cardiac arrest, having an ICD improves mortality. Okay, so the second time they get an arrest, the ICD can shock them out of it. Okay, or previously established ventricular arrhythmia. So if they had ventricular tachycardia or any such event prior, and that would qualify as a secondary prevention. And this would be a class 1 indication for ICDs. There are many other indications for ICDs, which I'm not covering today. If you're interested, please go through that link. There's a huge extended list available. And what would be primary prevention? So there were studies, Marit-2 from Boston Scientific and Scud Heft. All of these studies, they demonstrated that if you put in an ICD in a patient who've not previously experienced sudden cardiac arrest, but are at risk, that meaning that their ejection fraction should be below 35%. So if you have any of those patients, then they qualify also for, that's called primary prevention. Even before they had an event, you're putting it in. Okay? So those patients would also qualify for an ICD. So these ICDs can be pacemakers too, depending on whether the patients have any of those indications for pacemakers. They would also require that ICD for pacing. All right? And finally, the third category are the heart failure patients. So if you have patients with heart failure, specifically NYHA class 3 or 4 heart failure, and they have to be on optimal medical therapy, and they have a left bundle branch block, which meaning there are two branches coming down from, after your sinus node fires. You have the conduction system going to your His-Purkinje system, and from the His bundle you have two bundles coming out, one to the right, one to the left. The right side will help in the contraction of the right ventricle, the left side will control the left ventricle, right? So if there is any dysynchrony between the contractions, that means the left bundle has a block, the right bundle is going to contract first and then the left bundle. So it's not going to be, that your ejection fraction depends on your LV contraction, right? So if there is a dysynchrony between the two, you would have a wide QRS in your EKG. And if the QRS complex is greater or equal to 120 milliseconds wide, and it represents a left bundle branch morphology, those patients, and they have an ejection fraction of less than 35%, those patients would get ICD, a biventricular ICD. I'll explain to you what that means, okay?
Dr. Say, how do they define optimal medical therapy? Is there a time frame for 3 months, for 6 months? Do they define that any further?
No, they have to be on medication for heart failure,
Okay.
related medication when they get this device,
Okay.
or after they get this device. So the device alone is not going to be effective in reversing heart failure, but you will also have to be appropriately medicated for you to get the device. So just the different types of pacemakers. So this would be an example of a single chamber system. So single chamber meaning you're only putting one lead in the patient. Can be either in the atrium or in the ventricle. Okay? Typically in Europe, they have, for people with sinus node dysfunction, or where the atrial node is not able to fire properly, they would just put one lead in the atrium. It's not recommended in America. In America, we put two leads. We'd always put a backup ventricular lead. Okay? However, in Europe, it's perfectly fine to put in an AI pacemaker. Right? Remember, that's not for this country. The VVI pacemaker is, however, common in some patients. Let's say a patient has atrial fibrillation. The top is going like this. But they're conducting through to the ventricle. But sometimes when you have AFib, you can have conduction issues and your heart rate is going really slow. You want a pacemaker in those patients, and they're symptomatic. Right? You put in a pacemaker, but now you don't need to really bother about the atrium because there's no AV synchrony here because the atrium is fibrillating. Even if you put in a lead there and try to take the atrium, it's not going to capture that chamber. Right? So you only want the ventricle to be paced in that case. So we would put a single lead in the right ventricle. Is that clear? All right.
So what does the VVI mean then? Your ventricle?
Yeah, I'm going to go through
Oh,
the NBT
okay.
codes at the end of this. I guess I should have done it before, but nevertheless, you will catch up with it. So the dual pacemaker system is typically, in America, for patients with complete heart block, you have a sinus node is still intact, your sinus is going at a particular rate, but your ventricle is kind of dissociated from that rate. You would want to have a dual chamber system to establish AV synchrony. So you're sensing your top chamber and you're pacing the bottom chamber, all right? Or you're pacing the top chamber in case of sinus node dysfunction and sensing in the bottom chamber because your conduction system is intact, all right? So that's where the NBG code would come in, and I'm going to explain in a moment once I go through all these different codes. All right, so this is kind of a picture showing you the dual chamber pacemaker system. So this is the atrial lead here, and if you can see here, this is the lead tip and it's extended out. There's a helix there at the tip. And this atrial lead is placed in the appendage of the right atrial appendage. That's typically where it would go. The order in which the leads are placed is usually the ventricular lead goes first. And anybody tell me why? Why would you put in the ventricular lead first? Let's say a patient has heart block. Why would you put in the ventricular lead first?
Because you want to pace that ventricle first.
Yes. So, if required, me in the room, while I'm assisting the doctor, would be able to keep the ventricle paced and hence keep the patient safe. Right? That's the only reason why you would put the they would place the ventricular lead first. And it's usually placed in the apex, the right ventricular apex. Some other physicians would try to go to the septal region instead of the apex because the septal wall is thick. Chances are, if you put it in the apex, you might perforate the heart because it's thin, there, right? Because you're screwing out this lead, comes out, and then it embeds itself in that tissue. It might be safer to go septal. So a lot of doctors have been trying to go septal. Also, going septal is closer to the His bundle, so they can achieve a narrower QRS while paced. Of course, now Medtronic has the His bundle lead available, and some doctors, like especially in White Plains, they are able to go and place the lead right on the His bundle. And you can pace off the His bundle, and the QRS complex that comes off that pacing would be really narrow. So can you guess what kind of a bundle branch block morphology pacing the right ventricle would give you? Can you take a guess? If you pace, because you have your lead part predominantly in the right ventricle, right? If you pace the right ventricle, what would it possibly look like on the EKG?
Right bundle?
A left bundle.
Left bundle.
Because you're exciting the right before the left.
Oh.
So the morphology on the EKG on a 12 lead would resemble that of a left bundle branch block when somebody is paced with a pacemaker. Okay? And also, pacing more than 40% of the time in the right ventricle is not very good for the patient because it might eventually lead to heart failure because you're going to be pacing one chamber predominantly. You might cause LV dysynchrony. So now, recently, they've come out like Block HF is a trial that Medtronic did in 2013, and they showed that patients with 50% or less ejection fraction, or 50% or lower than that, those patients that have any kind of a heart block, it can be first degree, second degree, third degree heart block, those patients can qualify for something called a CRTD device, or CRTP device, or a cardiac resynchronization therapy device. That means you have 3 leads going in. Okay. Can I show you 3 leads here? This is just the dual chamber. I don't know why I don't have the. Okay, so this is a triple chamber system, which is what I was talking to you about, the CRTP. So that means it can deliver a bi-lead pace, meaning that it can pace the LV and the RV, the left ventricle as well as the right ventricle, and try to synchronize them. Okay? Medtronic has algorithms that can help with synchronization of these ventricles. And it depends on the A to V timing and the V to V timing. Okay? If you can standardize these two, that means the Medtronic algorithm would basically measure the AV delays every minute, and it would try to try to pace the left ventricle earlier than the right ventricle, and try to synchronize the 2 chambers and achieve a narrower QRS. Okay? So this is, in addition to the His bundle is one way of achieving synchrony, because you're using the conduction system itself to pace the ventricles. The bi-V system is another way to achieve synchrony, or this was the first primary way, and now His bundle has come along. The technology has grown. Okay, so this is another way doctors would achieve pacing. Let's say you have a infrahisian block. The AV block is below the bundle of His somewhere along the line. If you put a His bundle lead, it's not going to do anything, right? So in those cases, in those scenarios, this would be the go-to method. In this method, you would place the 2 leads, one in the right atrium, one in the right ventricle, as usual. Those would be placed first. You put the right ventricular lead, then the right atrial lead, and then you would put a 3rd lead into the left, potentially pacing the left ventricle through the coronary sinus. So how many of you know where the coronary sinus is in the heart? Anybody else? So it's located posterior in the right atrium. So when you're going through the right atrium, it's located kind of posterior portion of the heart, just before the tricuspid valve. Okay, so that's how we have special catheters that can cannulate this particular coronary sinus. And once you get into the coronary sinus, you would look for a lateral branch, and the lateral branch would if you remember how the heart is located, the left ventricle is kind of posterior, all right? Posterior lateral position. And then if you're looking in an AP view, you would see, what you're seeing is mostly the right ventricle. You'll see a little bit of the left ventricle if you took a picture like this. So if you wanted to get to the left ventricle, you have to go a little bit lateral, posterior lateral, with that when you cannulate the spleen. Fortunately, I don't have a model. Maybe it could be a conversation for one of your other grand rounds. If you want me to come talk about exclusively how you can achieve synchrony, I can do that too. All right? So now the NBG code. So this comes back to your question of what the BVI mode was. All right. So the NBG code is usually a 3-letter code. Here there are 5 letters. The last 2, don't worry about that. For the purposes of this presentation, let's stick to the 3-letter code, okay? The 4th letter would be whether you turned on rate response, something called rate response or not. Okay, let's not even think about that. Let's stick to this. So the first letter of the NBG code denotes the chamber that is going to be paced. So let's say you had an A there, which chamber would be paced? Anybody? If the first letter was an A, what chamber do you think would be paced?
Atrium.
Atrium. If the first letter was a V, which chamber would be paced? And if it's D, what do you think would be paced? Both of them, right? The second letter of the NBG code is which chamber is being sensed. So the leads, if you know, they are bipolar, so they have a cathode and an anode, between which you can sense electrical impulses in the heart. Okay, so the ability of the lead to sense a particular chamber is very important. If it's not able to sense that chamber, it's just going to pace it, right? And unnecessary, we don't want unnecessary pacing. Okay, remember that pacing is bad, even though it's unavoidable in some cases. Pacing in general is bad for the heart. Okay, so especially the ventricle, not the atrium. Right? So so the second letter denotes the chamber that is going to be sensed. So if you had an A, what chamber would be sensed? Atrium. And then if you had B, it would be the ventricle, and if it's B, it would be both. And if you had an O, what does that mean? Nothing. Nothing's going to be sensed. And this doesn't matter. The S, forget about that. These four are the most important. And O means none in all the cases. And the third letter would denote the response to this sensed event. Okay, now VVI, the I means inhibit. Okay, so the response to the sensing event would be inhibit. So in VVI, what do you think will happen? Let's say you set the pacemaker at VVI 60 and the patient's heart rate is 65. Will the pacemaker pace?
Down at 65.
Why?
It's too high.
Yeah, but
The rate is
explain to me based on the NVG program what would be going on.
It's inhibited.
Yeah, it's inhibited based on the sensing, right? So it
Based
can
on
sense at 65,
But
it's
it
going to
won't.
inhibit
Okay.
pacing. Alright? So the same pacemaker at VVI, patient's going at intrinsic heart rate drops below 60, pacemaker cannot sense an event at 60 beats per minute, the second beat. So it will trigger, it will pace. Okay? It won't inhibit. That's what VVI means in the very simplest of terms. Same thing with AAI. Right? So now DDD. Right? So if you in DDD is in most dual chamber pacemaker would be programmed to DDD if the patient has a heart block. Because you want to pace both chambers if it goes below the set lower rate. Okay, let's say the lower rate is 60. If it goes below 60, you want both chambers to be paced. You want to sense both the chambers. And the response to sensing would be either to inhibit or to trigger pacing. Okay, this D either can inhibit or trigger. So the response to sensing would be to inhibit. The response to not sensing something at 60 would be to trigger pacing. Alright, so when a pacemaker is programmed, let's say 60 to 130, it means that if the patient's heart rate is going between 60 and 130 on its own, it's not going to pace. Only if the heart rate drops below 60 is the pacemaker going to trigger pacing in both the chambers. You get it? If the atrial rate is above 60, it will only pace the ventricle. If both the rates go below 60, then it's going to pace both chambers. And also the pacing, so when you are in the DDD mode, there's another issue that comes into play called the AV delay. The AV delay is the time taken from the time you trigger the atrium to the time the ventricle is triggered. So there are two types of AV delays that you can program in any device. One is called a sensed AV delay. The other one is called a paced AV delay. That means if your atrium is paced, your AV delay would be a different number. So usually we set the paced AV delay to be higher than the sensed AV delay. Because remember that cell-to-cell conduction is faster than paced conduction because you're capturing a whole big region of the heart and the conduction system, you're not going through the typical His-Purkinje system for your conduction to be fast. You're relying on cell-to-cell conduction, which is much slower. So that is why your paced AV delay would always be higher than the sensed AV delay. So if you're sensing an atrial event, the chances of your conduction to the ventricle, like you will trigger the ventricle a little faster than when you're pacing an atrium. Okay? Because you're assuming that the sensed pulse went faster to the AV node, and therefore you can trigger now, like you would put that time a little faster, okay? So it also depends on what the intrinsic conduction of the patient is. Let's say a patient's PR interval or AV interval, let's keep it simple, the AV delay from time from the A to the V, intrinsic, like they're coming on their own at 200 milliseconds, let's say. So their sensed AV delay, I would keep a little longer than 200 milliseconds when I'm programming a DDD. So I would probably put it at 220 so that they can, so A sense, V sense, or A pace, V sense at 220. But if they don't have intact conduction, and they have some people are always not on a heart block. They have, they go frequently or occasionally in and out of heart block. So for those patients, you would have to set the AV delay appropriately that they're not pacing all the time. If you kept too short of an AV delay, they're going to keep pacing all the time because their intrinsic pace AV delay is at 200. And if I set their pace AV or sense AV below 200, they're going to be pacing irrespective all the time because that AV delay is crucial in determining whether they will be paced or not. So in the DDD mode, all those things come into play. Okay, remember that AV delay comes into play. If you want more explanation, you'll have to do a separate course on that. Okay, and then today our primary talk is going to be about magnet placement. Okay, now I'm going to go into that. And why is that important? It becomes important during surgeries and stuff like that. So on magnet placement, electronic pacemakers pace in an asynchronous mode, DOO or VOO. What do you understand by asynchronous? Anybody? Why would a DOO or a VOO mode make it asynchronous?
Stop sensing? Stop sensing?
There's no sensing, there's no response to sensing. So it just paces at a particular rate. So in a Medtronic pacemaker, a patient comes in with a Medtronic pacemaker, you put a magnet on their device. If their battery is good, battery life is good, it's going to pace them. If it's a single chamber pacemaker, it will go VOO at 85. If it's a dual chamber pacemaker, it's going to go DOO at 85. It doesn't care about what the underlying thing is or anything of that sort. And when the battery reaches RRT, or recommended replacement time, meaning that there's 3 more months left when it reaches that voltage, Medtronic pacemakers on magnet placement will pace at 65. So you've got a patient here and you want to evaluate their battery status, and they are from Medtronic, they have a Medtronic device. Putting a magnet would immediately tell you can look for spikes at 65. If they're 65, constantly you see spikes after you place the magnet, their battery needs to be replaced. And if they're going at 85, so a magnet can tell you a lot about the device, all right? Especially pacemakers. This is different for defibrillators. Okay, now I'm going to go into the next step. So before we go into all of that, when a patient walks in, what are the things that you would need to figure out before before you try to use a magnet on them, right? So you have to identify whether they have a pacemaker, an ICD. So these can be either single or dual, both of these, or a CRTD, which means they have 3 wires, right? And this has a defibrillator function. Or it might be a CRTP, which is a pacemaker, right? But has 3 wires. One in the atrium, one in the right ventricle, one in the left ventricle. All right? So you would first look at their ID cards to make sure what device they have. Some patients won't have an ID card, and still the magnet function is going to help you find out. So I just showed somebody a week or 2 ago how you could use a magnet to figure out whether it's a Medtronic pacemaker, is it a Boston Scientific, is it a Biotronic. You can tell all of that if they have a pacemaker just by placing a magnet on the device. All right, and we are going to go through, towards the end of this presentation, I hope, you'll get an idea on how to do that. And also, there's a link I've sent with a paper from Europace Journal that actually lists the tables that I'm going to show you. Okay? So the front would give you the model numbers of all the leads and the device information right in the front. And the most important thing is to identify whether it's a pacemaker or an ICD, and when it was put in and all that. And then you evaluate the medical record. So this is before a patient goes into surgery. Okay, you would evaluate the medical record, and then you can look at the ICD and pacemaker encyclopedia to figure out what that device is, what type of device they have, or you just call this number and they'll tell you what device they have, when it was put in, if they don't have an ID card. All right, you can just call Medtronic, tell them, hey, I have this patient, this is the patient name. They claim that they have a Medtronic device because usually they don't know. All right. So they can look up the database and tell you. And if it's not Medtronic, then you call Boston or you call the other device company, Biotronic, and so on.
I'm sorry, Dr. Sal, you said that's 24/7. There's somebody there to answer?
Yes, that's the National Answering Service. So you could call them anytime and they should answer. All right? And so this is just how the magnet function works. Like I already told you. So the single chamber is going to go VOO or AOO. Remember, we don't have a pacemaker. In the US, you wouldn't find patients with a lead only in the atrium. You might, if they have migrated from some other country, or they came from Italy, or some European country, you might find somebody with just one lead in the atrium. That's possible, but not somebody who was implanted in the US. This is rare. You'll never find that. So it would go VOO usually at 85, and then when it reaches recommended replacement time, it would be at 65. And then, of course, if they doesn't matter with VDD, forget about that. That's too complicated. But it means that it only has a single lead that can sense the atrium. There are some devices that you can put for a patient with a heart block. That don't have sinus node dysfunction, their sinus is intact, but they have heart block. You can put a VDD lead, which can sense the atrium. It has the same lead, has an electrode on top that can sense the atrium, okay, as it goes into the ventricle. So that's a VDD lead. Forget about that. You will not find too many of those patients in this area. And you have the dual chamber. If they have a dual chamber pacemaker, it's going to go DOO. Right? So, and the magnet will cause it to pace permanently programmed operation within 2 seconds. Okay? Once you take it off, it will go back to whatever it's programmed to, so you don't have to ask us to come check the device unless you think there's an issue while they did the surgery. Okay? So this is an example of an EKG, a CRTP actually, that had a magnet placed over it, and then it went DOO. So the first 3 beats in a CRTP would be 100 beats, and then the rest would go to 85. So there's a slight difference if they had a CRTP. Okay? And this is close to end of life, they're just going at 65. RRT, I told you, it reaches recommended replacement time. So, why would you put a magnet on during surgery, do you think? Can anybody guess? Why would a magnet be useful?
Is it because there's other electrical, because of the electrical cautery they use?
So, what do you think the cautery would do?
It would affect the way the pacemaker is moving?
So it all harks back to the NBG code, right? So you're always in some kind of sensing mode. When you don't have the magnet on, the magnet puts it in an asynchronous mode, which won't sense anything, right? But however, when a normal patient will be programmed to some mode that can sense the ventricle. And in those patients, when you're using electrocautery, you can have something called noise on those leads. And the noise would be sensed by the device, and the device will think, okay, so there's some sense ventricular event going on, so I'll inhibit pacing. Right? the response to sensing is inhibition, usually, right? So if you had those, most of those pacemakers, or 100% of them would be in that mode, and then if you use cautery for a long period of time, it's going to inhibit pacing in those patients. So the safest bet for this patient, just put a magnet on them. So they would just keep pace during the procedure. When you're using cautery, put the magnet, they go to 85 beats per minute, and then take off the magnet, they go back to their programmed settings. Is that clear? And the other use of a magnet is, let's say, this never happens in a Medtronic device, but there are other devices that don't have quite the great algorithms that we have to ensure a patient doesn't get into a PMT. Anybody aware of what a PMT means? Pacemaker mediated tachycardia. Okay, so simply put, there are some patients that would have a retrograde pathway. So let's say you pace their ventricle, right? There would be a sensed atrial event following the ventricular event, because there's a retrograde pathway that's available in those patients that would basically trigger the atrium after a ventricular pace event. So this atrial sense, or this event should fall, if it falls in the refractory period of the device, it won't be tracked. However, if it falls into the sense period where the device can sense that event, it will just start pacing, tracking that event. So now the patient is in tachycardia because they are following their retrograde T waves. Okay? And then if you put a magnet on such a patient going through PMT, that will break this. Because it's going to go asynchronous and can be helpful in breaking PMTs. Alright? Because it would prevent tracking of these events and give relief from a PMT. Okay. This you don't need because you don't use the programmers.
So if they have a pacer defibrillator, you would use the magnet also? If it's a pacer defibrillator?
There's
Or
different.
that's-
The magnet function is different for a defibrillator. Now I'm only talking about pacemakers. Okay. I'm going to come to that in a little bit. So this is your question now. Magnet function in an ICD. It is very different from a pacemaker. Putting a magnet on an ICD, any kind of device that has a D at the end of it, meaning that it has a defibrillator function, especially a Medtronic device, will not affect the pacing function of the ICD. It's not going to do anything, make the pacing asynchronous or anything like that. All that it does is to block any kind of therapies from being delivered. So remember, the ICDs are devices that are capable of detecting ventricular arrhythmias and reacting to them. Basically, you shock the patient out of a ventricular arrhythmia. So in the same situation, patient having surgery with an ICD, you would put a magnet on because the cautery will cause noise on the lead that might be construed as a ventricular arrhythmia, and therefore the patient might get an inappropriate shock. So whenever an ICD is involved, the magnet only suppresses the therapy or suspends the therapy. It doesn't do anything to the pacing function. It's very critical that you understand this. Okay? And so this is an EKG with electromagnetic interference. Okay, patient with an ICD has EMI, and this doesn't. They don't have a magnet over it, and so they will just get shocked with or get an ATP therapy from the device because it's inappropriate. There's noise because of EMI, and magnet use would prevent that. Basically, just suspend any detections and prevent them from getting shocked. All right. So when you put the magnet on an ICD, this is what, on the programmer screen, this is what you can see. It would say suspended, meaning that all these therapies on a programmer screen, I don't know how many of you have looked at an electronic programmer screen. Have you ever? So if you look at the programmer screen, on the top left, we always have the mode the patient is set at, and then you would have whatever therapies are turned on. So in this case, VF therapies are on, FVT or fast VT therapies are on, and the VT zone therapies are on. Okay, so this means that all three. So if there's somebody coming in to check your device, this is what we would look at first, because okay, these three are on. Make sure that they are on, because your ICD patients, you have to have those therapies on. And when you put a magnet, it just suspends all of those therapies immediately. Okay, after you put a magnet on, you will get a long tone and it will suspend therapies. And I'm going to demonstrate those tones in a little bit. So if your device, let's say you're doing your surgery and all that, there is a possibility that if you're too close to the device, you might cause an electrical reset of the device. Okay? If the electrical reset occurs, the device, so these are the things that can cause electrical reset. So if you put an external defibrillator pad right on the device and and you defibrillated the patient, you can cause an electrical reset. And it looks exactly, the pacing spikes will look exactly like a magnet mode even without placing the magnet. And that's when you have to call one of us and say, hey, something's wrong with this device. They were doing this surgery, they did the cautery too close to the leads, and we think there might be an issue with the device. Then you would call Medtronic immediately after the surgery and we would come and take a look. Okay? And when it undergoes a full electrical reset, the pacemakers would be pacing at a lower rate of 65. It will switch to this mode, BVI mode. Okay? And ICDs, there might be a full electrical reset that will also cause them to pace at 65 beats per minute. And you would see a high urgency tone alert in the device that will keep beeping every 9 hours. And you would have to call us and we have to reset the device to the parameters.
So it actually makes a noise, the pacemaker?
The ICDs. The pacemakers will not make that noise. It will just operate in VVI 65. So just like, as if a magnet was put in and it's at end of life or something. But it's not going to. So now this is kind of showing you proper magnet placement. You have the patient on the table. What would you expect? This is a pacemaker. So he's going at 72 beats per minute. We put the magnet on. Now he started pacing at 85. Right? Single chamber, VO 85, same thing we discussed. And that would basically tell you whether your magnet is placed properly or not on the device. If you see that, then you know the magnet is properly placed. And now I'm going to show you what happens to the ICD. So now you're putting a magnet. You'll hear that tone. You hear this long tone, meaning that it's right on top of the device. Okay? And then it'll stop. And then it means that you've placed it right on the device and now all the therapies have been suspended. Within taking the magnet off, like 2 seconds after taking it off, it will return back to normal. Okay? It will start detecting arrhythmias and all of that.
What if you didn't wait the 2 minutes? If you said, oh, and you took it off? You have to wait the 2 minutes?
No, you have to keep it on
Yeah.
during surgery.
Oh, yeah.
When you take it off, it goes back. It just will make that initial tone to tell you that you're right on the device.
Spot. Okay.
So this, a beeping oscillating tone, means that when you put the magnet on, hear this tone?
Yeah.
If you hear this, that means there's some alert conditions that exist. Okay? That means there's some kind of alerts that are in the device, you might want to call us if you hear that tone. If you hear that clear tone, it means that there is nothing like that. So, for instance, you've just been through the surgery, you put the magnet on, initially you hear this long, clear tone, and then surgery is done, you took the magnet off. Another thing you should do is put the magnet back on to see if you get that long, clear tone. If you hear this alert that you just heard, call us. Something's gone wrong with the device during surgery. If you heard the clear tone again, means it's perfectly all right. Send the patient home, or to wherever they have to go. You don't have to check the device. Okay? All right, so what are the advantages of using magnet versus calling one of us to reprogram the device? So there can be two ways of disabling the device, right? You either call us, we can do it manually, or you just use the magnet. So what are the advantages? The advantages are you can quickly remove the magnet and make the device go back to its original function. Okay? You can eliminate the manual reprogramming because you have to go, you have to call me, I have to come here. There's a lot of logistics to that. And then, independent patients, you can ensure that they will be paced during your procedure at 85 each just by putting the magnet on. All right? And reprogramming, you have to, the advantages are you don't have to be worried about whether you put the magnet on the right location or not. Okay? And then this is the most critical point that I would like to drive home. There is one particular situation, no matter what, you want a Medtronic person here. It is when you have a patient with an ICD and they are pacemaker dependent also. Okay? Most ICD patients will not be. However, there might be some that are. You want to figure that out with their cardiologist before you go into surgery, because remember, a magnet does nothing to the pacing function. So if those patients are going to undergo surgery, you would want us to manually turn off the therapies as well as detections, as well as the turn on an asynchronous pacing mode before you go into surgery. Okay? So those are the advantages of having us, especially for this particular, patient. And what are the disadvantages? So the magnet does not provide asynchronous pacing ICD patients, like I told you, those are pacemaker dependent. That's the key critical point. And basically, the magnet won't make the device keep beeping all the time, so you know that it's appropriately placed. So the first time you place it, you have to ensure that you're placing it right over the device, and you hear that long tone, you're fine. If you move that later, you might not know that you made that mistake. So I would recommend taping it, if possible, to that location. So, and again, if your surgery requires a patient to be in an awkward position where your magnet is going to fall off, that's again a disadvantage. Right? So, and then disadvantages are that you can't readily reverse the programmer settings. And I'll tell you why this is important. There can be real-life scenarios that you can actually help you with by using a magnet. Would rather help you than calling one of us to reprogram the device. And I'll show you one such example. So this is the example. So let's say during a medical procedure, you have an ICD patient, they develop ventricular tachycardia. You have the magnet on them. What would you do?
Take the magnet off.
Take the magnet, exactly. So that is the situation where the magnet is going to help you. If I turned off therapies, you will have to manually defibrillate the patient. Now in this case, you see the VT, take the magnet off, device does its stuff, and you put the magnet back on. And they're back in normal sinus, you can continue the surgery, or you will abort it, whatever. But the magnet is going to be very helpful in taking it off. You can take it off if you detect any tachycardias, and it will ensure that the device is going to detect it and treat it. Okay? And pacemaker, let's say I put it in an asynchronous mode and I walked away. And they went into some kind of a sinus tachycardia. Now, What do you know about the asynchronous mode that's not so good for the patient, especially in these conditions? Asynchronous mode is not going to be worried about what the intrinsic rhythm is. It's just going to pace them at 185 beats per minute. Let's say the patient is going to go, has a sinus attack, and they're going to go 100. What might be the issue there? What could happen potentially if you deliver a pacing spike where it's not supposed to go? Yeah, so what might happen? You can get it to, the patient can potentially have VTAC. So if you identify that, when you have the magnet placed and you see them going fast on the EKG, because the magnet is only going to pace at a particular rate, but you will be monitoring the EKG to take the magnet off. Don't allow it to pace so you don't get into a potential situation like that. So that is why magnet use might be better than even reprogramming in most cases. Right? And basically, a programmer for ICD patients is the same thing I was talking about. So this is just some scenario, okay? Scenarios that you'll go through. So this patient has a pacemaker and ICD, and then they're being scheduled for a colonoscopy in an hour. Electrosurgery may be used. And the chart says patient has a Medtronic ICD, not pacemaker dependent, critical. And patient confirms that their cardiology has been routinely checking the device and the device has no issues. So you go into surgery. What would you do next? Which of the three choices do you think you would pick?
The first one.
So you would just prepare the resuscitation equipment and then have the magnet available, right? That's the right answer anyway. Let's go to the next one. So that's the answer, and it would suspend protection. So this is another EMI situation. Now the pacemaker, the patient is scheduled for electrosurgery. It's below the umbilicus, and they're going to use a monopolar system, so that means it's a bigger antenna, and it's going to be more than 6 inches from the device. The patient is pacemaker dependent, has a Medtronic pacemaker. What would you do? Monitor the patient closely, request to reprogram the device to asynchronous mode, or initiate magnet mode by placing a magnet if pacing inhibition is observed during the procedure. Okay. So you use a magnet, which is the most appropriate for that situation. Now this is another case study. Patient has a Medtronic ICD. You use the magnet as usual. They went into this rhythm during the procedure. What would you do?
Take the magnet off.
Yeah, you remove the magnet and then let the device do its job. Yes. So, if the magnet placement is appropriate during perioperative, then the healthcare provider is responsible for selecting the most appropriate options. So your doctor, you have to talk to them, and then depending on the patient's individual needs, you would choose the best option. And then there are some guidelines to that, which you can, there's a HRS, ASA. So I've sent the presentation to you, which has these links that will be active, and they can go through that and then, learn for your own enlightenment.
Lisa, would you email that to everybody?
Yeah.
I'll give you the list?
The links.
Okay.
And so you cannot use a magnet because a Medtronic programmer and competent operator is required. Cannot be used, then you would call one of us competent enough to use the program. Okay, and confirm you would put the written order in the chart saying that you want it in a particular mode so that we can put it in that mode. You should have some kind of an order so you can do that before the procedure. The patient should be properly monitored, connected to external pacing, defibrillator, blah, blah, depending on what they have. And for ICDs, you must ensure the detections are turned back on after the procedure, make sure that become and turn it back on. Okay? Especially for ICD patients that are dependent, pacemaker dependent. Okay? So I guess I've pretty much covered most of the stuff that you should know. And you can go through this presentation that has, like, I have magnet use versus all these advantages, disadvantages, all of these I think you can read. Medtronic policy basically saying we are the last resort, use a magnet if when possible. Okay? And now I want to get into some of the stuff. So what happens with magnet placement in other devices? We've talked about Medtronic so far. All right, so you have a patient now, you don't know which company they have a device from. You know that they are from Europe. So none of the companies will be able to pull out, what device they have. In that situation, with a pacemaker patient, you could do the magic of using a magnet and figure out what company they have. And this is not something that never happens. That happened with me recently. They called me, they thought they didn't know what company the patient had. So we just put a magnet on and we saw this situation. So when I put the magnet on, we saw that they were going asynchronous for about 10 beats, okay? And then they returned to their normal level of normal pacing, whatever they were pacing. So we figured out that it's not Medtronic, it's not Boston Scientific, that it was a Biotronic device because of that. Just one simple method, put the magnet on, go to telemetry, figure out what's happening on telemetry, record that event, see where the pace, what the rate is, and you can, based on that, tell what device they have. This will be very useful when you have a patient who doesn't remember, or you just wanna. This also will tell you whether, their battery is good or not. There are two things that will help do immediately and eliminate all the other possibilities. Okay, and Medtronic, you know what happens when you put a magnet. Boston Scientific, it goes to 100. When if it's good, the battery is good, and then it'll slowly start. In the middle of life, it'll go to 90. There's different pacing rates for different battery levels. Okay, and then St. Jude will have again different pacing rates. Goes to AOO or VOO will be at 100, and then it'll go between 80 and less than 85 when it reaches ERF. So again, all of these can help you figure out Sorin. You will rarely find that device, but you might have a few patients with that. So this kind of gives you a good idea. This paper was also, I sent you a link yesterday. So if anybody is interested in reading this paper and having this chart, maybe just paste it somewhere, So telemetry technicians would be able to do this immediately, figure out a couple of things before they call the companies, And that would be for pacemakers. These are for ICDs. So different companies work differently for ICDs too. You heard Medtronic, you heard the all-clear tone. If you have a low urgency tone, it means that some alerts are on. And then if you have a high urgency tone, a big beeping means you have to call us at the end of the procedure, And Boston Scientific has a different, it basically suspends tachytherapy by putting a magnet on, but however, they do have a mode which will ignore the magnet. So you want to make sure that that is off in those devices. So Medtronic is pretty simple. There's no mode that would ignore the presence of a magnet. All right. Boston Scientific, however, has that mode where it can ignore the magnet, so the magnet won't interfere. And St. Jude also has that ignore magnet mode, which you might want to make sure is turned off before you use the magnet. And Biotronic is simple, and Sorin also, just like Medtronic, would turn off therapies. But however, they don't have any audible noise to let you know whether you put the magnet in the right place or not. So So I hope, so now we've come to a different topic now. So the magnet function, I hope everybody understands it. This is something that we have now working in the ER here. This is the existing system. I want to show you what this is. This is called a Kelling system. So if you had a patient walk in with an ICD or a pacemaker or any of those things, Medtronic, anything Medtronic, a cardiac device, you could potentially just use this to send a transmission to one of us within 5 minutes. So once you send the transmission, we will get the complete report in 5 minutes, and we can talk to the person, like talk about their device longevity. We'll even give us a current EGM, so we can figure out whether the device is working properly or not. And it just cuts short the amount of time. It saves money for everybody, you know, and by mobilizing people faster and also clearing your beds off faster, because you know you don't want the patient staying there for too long. That's the whole purpose, because sometimes we cannot. I'm in a case somewhere down in the Bronx. It'll take me an hour or two to get here, or even longer. Then it, you know, the patient just has to sit there waiting for me when they could potentially the problem is not with the device or anything associated with the device. So this kind of is a useful system. I'm going to go through the video with you. However, what I'm excited about is the next video, because we're going to replace this with iPads. Okay, and this technology is coming to the floor near
In
you.
the next several minutes, you'll see how a CareLink Express monitor is used to interrogate Medtronic patients with implanted cardiac devices. This pre-assembled kit contains 2 CareLink Express monitors, one that's blue and one that's gray. The kit also contains a cellular accessory, cords, and batteries. The gray monitor is used to interrogate most legacy pacemakers. The blue monitor is used to interrogate pacemakers manufactured after 2011 and all ICDs. If you're unclear about which device the patient has, start with the blue monitor and the reader. If the blue monitor doesn't identify the patient's device, use the gray monitor and reader. Both monitors work the same way. For purposes of this training video, we will use the blue monitor. The first step is to push the power button on the front of the monitor. The green light above the power button will blink, and then it remains lit. Hold the reader, which looks like a computer mouse, directly over the patient's implanted device to begin the interrogation. Please note, you can only retrieve information from the patient's device. You cannot change the programming in the device or turn off the device. While the reader is over the device, the following takes place. The first reading status light turns green and beeps twice when the monitor identifies the implanted device. A blinking orange light indicates that the monitor cannot identify the implanted device,
So
or
then
that
you
the
switch to
reader
a
is in the
different
wrong
monitor.
location. Reposition the reader over the device if this happens. All indicator lights turn solid green and the monitor beeps twice when the implanted device interrogation is complete. Remove the reader once the interrogation is complete. If the interrogation is not successful, the implanted device may not be from Medtronic and the interrogation will not work. Within 15 minutes of the interrogation, make sure the cellular accessory is plugged into a power outlet and has a strong cellular signal. Once connected, the monitor will beep 5 times every 25 seconds until a connection is established. The monitor turns itself off, and then you can unplug the cellular accessory. After the interrogation is complete, the data is sent to a device specialist for review. This specialist could be someone within your hospital, or it could be a Medtronic device specialist. It all depends on your profile.
So the second step, it takes longer than what they've shown. So once you plug, after the first, within the first 15 minutes after the first interrogation, you see that when you saw those 5 lights light up, plug the wire X and leave it for another 15-20 minutes, because it can take that long to send a transmission. And preferably put it in an area which is, you know, where the signal is strong, because it uses cellular network. And we've had issues with the ER with this. Okay, however, this is going to be an outdated system. We're not going to use this anymore. We're going to use this starting in the next few weeks. Okay, And this is what I want most people to be trained on, because this will be an iPad, and it will be, the iPad will be connected to your network here.
In this video, we'll demonstrate how the CareLink Express mobile system is used to interrogate Medtronic patients with implanted cardiac devices. The CareLink Express mobile system consists of a patient connector and cords for charging. The system operates using a free downloadable app and a mobile tablet. A list of compatible mobile tablets can be found at medtronic.com/CL Express Mobile.
I think we got the iPads for you
Your
already.
Medtronic representative will set up an account profile for your CareLink Express mobile system. This profile will include a security code that is connected to the serial number on the patient connector and a location ID number. Once the profile is configured, your Medtronic representative can work with your IT department to make sure the mobile tablet is connected via Wi-Fi and that the app is downloaded. The free app is downloaded from either the iTunes Apple App Store or the Google Play Store. Once it's downloaded, the app resides on the desktop of the mobile tablet being used for device checks using CareLink Express Mobile. Now it's all set to go. Once you open the app, all you need to do is perform a patient's device check by following the animations on the app. Step 1 shows where the app starts. Just hit the button on the patient connector to start. The app will need to be paired with the patient connector. This can be done by your Medtronic representative during the initial setup. The patient connector is placed over the patient's cardiac device, as shown in this animation. A green light will appear on the patient connector indicating a connection has been made with the patient's device. This means you can start the interrogation. While holding the patient connector over the patient's device, the app will display a green progress bar that lets you know the connector is positioned correctly and receiving data from the patient's device. A new screen will appear on the app indicating the device data is being sent over a secure network for review. Once all of the data has been sent, a green check mark will appear indicating the data was successfully sent. That's all there is to it. The data will be sent remotely to a device expert who will review the data and let you know if the patient's device is okay. The tablet automatically transmits the data from the implanted device to the Medtronic CareLink network. The patient's clinic will receive this data if the patient is enrolled in remote monitoring. If the patient is not enrolled in the CareLink network, data will be available on the CareLink Express website for 7 days. The app will alert you if there is an error. The most common errors you might encounter are error code number 3269. 3 possible scenarios with this code include patient connector out of range. To correct this error, ensure the patient connector is turned on. Bring the mobile tablet closer to the connector and resume the connection within 30 to 40 seconds to continue the current interrogation. Or press cancel to restart the device interrogation. Error number 3269 could also mean an interruption of the Bluetooth connection, and all retry attempts of reestablishing connection have been exhausted. If this happens, ensure the patient connector is turned
I
on.
guess these are
Press
ancillary
cancel
things.
and
You can-
restart the device
yeah, It's
interrogation.
not so important, just troubleshooting.
If you see this screen, it means a temporary interruption of the telemetry connection.
So, I guess, so that's basically the end of the presentation, and, you know, these are the 3 people in your area, I'm one of them, and if you have any questions that we will have to answer, or if you don't, then that's fine too.
I have a quick question. In a code situation, say a patient's like in respiratory arrest, you would just leave, you would just watch the pacemaker spiking on a Zoll, and if they had like an ICD, they would still get shocked accordingly if something did happen.
Yes.
Okay.
So if you use a magnet, then you just take the magnet off, and if you saw them go into retap, and it would appropriately.
All right, so I was gonna go over the transcutaneous one real quick. All right. I have a PowerPoint, but I'm not gonna do it. All right, so I'm just gonna go through it. So the big thing is, you know, getting the pads on in the right way. But before you even put on the pads, you have to put on the lead so you have somewhere to sense, okay? So put the leads on the patient first and do a 12 lead first before you get the pads on, because otherwise you get all right, you know, you can't do this if they're really like, you know, circling the drain and, you know, unstable, but if you have time, you know, and you just put these on for like, a lot of times it's, we're waiting for meds to wear off, they're a little symptomatic from their heart rate being too slow, or, you know, maybe we over-treated that AFib. You know what I mean, and now they're having some pauses, you know. So we'll put them on this for a little while to wait for the meds to come out of them, or if they're waiting for a permanent pacemaker, you know, sometimes we'll have them on the pads. So the pads, a lot of times they come from the ER with the pads way too low, you know, especially on women because, you know, the breasts are in the way. So just remember where the heart is when you put them on, and, you know, there's pictures, they tell you exactly. And it really works much better anterior to posterior, okay? You can do the, you know, but the pacing really, you know, anterior to posterior. So if you're gonna, when you're gonna turn it on, make sure your MA, you know, your amount of, juice is all the way down before you turn on the pacers, all right? And you wanna just slowly go up on that MA until you get capture. You also wanna set the rate a little bit higher than what the patient's rate is when you're trying to make sure that you're getting capture. So that you get a pace beat, okay? So, you know, the rate is here, the MA here is, and you just turn it to the pacer mode, okay? And then once you hit capture, and you're seeing the capture on the tracing, you wanna make sure you're getting a pulse with that too, okay? So you're checking your pulses. And you want peripheral pulses, because you want them to perfuse, okay? Once you get the pulses, then you wanna go up on that MA just a smidge more. All right, just so you know, if you need to use it, that you're gonna get captured, okay? Then we usually turn the rate down to like 30. You know, most people laying in bed are not symptomatic. They're not gonna syncopize on you. We have patients that come in with a complete heart block. They've been walking around with a 20 and syncopizing at home. And then when they're laying in bed, they feel fine, you know? So, well, you know, so you can't even go less than 30. So those patients, we kind of just keep an eye on them and only pace them if they're become symptomatic. And the pacing's very uncomfortable. You know, getting shot through your chest is not fun. So we give them pain medicine if we have to, you know, pace them at all. But, you know, like I said, we only really pace them if they're symptomatic. And if they need the pacing for more than a little while, then we're going to put in the temporary wires, you know, the transvenous